co-moderator.
Hey guys. Do you guys hear us?
I can.
Hi. Good morning.
Good morning, everybody. Well, welcome to the first of many live cases.
Was that me fly fishing?
That was you fly fishing. That's right. We have some really great cases lined up for the forum this year. As always, it is an honor to have Mark Reisman here in the lab with me. It's always so fun. We do a right brain, left brain thing. He's the thought leader, and I'm just the grunt pushing balloons and stuff. So, but
Marionettes.
Marionettes, yeah. Who's our moderators?
Okay, we got me here, and basically my job is make sure this thing runs on time. Tim's my co-moderator. We put him at the other end to keep Mort in line. We've got the two Parikh brothers, who are really going to help us out. And then I got John Hodgson sitting right next to me.
Perfect.
Okay, that's perfect. Good, good, good.
So why don't you introduce the case?
Why don't I introduce the case? First of all, can we have the first slide? Yeah, I want to thank all my partners in the group. Man, they really came through in excellent fashion. I asked for some cases starting the beginning of January, and they really were terrific about offering cases. Nick Iyengar, Bob Burke, and Kevin Clausen was just fantastic, as he usually is. Can I see the next slide? I'll show you a case that there were two we were considering for today. Go next. This is a patient who had a previous 4-vessel CABG, presented with an NSTEMI, native right and vein graft to the right were both closed, and he's basically living off a lima to the LAD and this circumflex, or what's left to this circumflex. And Kevin said, I thought this would be a great challenging case for you. Unfortunately, the challenge heated up a little bit earlier, and so we fixed it before we went before the meeting. So go ahead next. And, you know, I show this case just because Kevin and others, I always tell them, use all the tools in your toolbox. We used a glider balloon. Go forward. And the glider balloon is this skived tip balloon that helps to get you down to places where you can't go. Go next. For some reason, okay, so there's the glider balloon across what was just a ratty-looking vessel. Go next. And then we came down with an expedition stent. Again, a great tool in the toolbox. Really a very deliverable stent. And I think if you looked at those first images, I wasn't so sure we were going to get across. Go next. So here you see the glider balloon, or the Xiant stent going down. Went down beautifully. Got it down to where we wanted to. Go next. And here is another expedition going into that other branch, and we'll just take this to the end. And then we dilated everything, and I didn't realize we were going to be able to dilate this with 3.5. With 3.5 NCs. Go next. Go next. So we did a multi-stent strategy, and this is what we came up with. And I think if you look at that first picture, go forward. If you look at that first picture, okay, to the left, and then look what we ended up with. I just really, it was a fantastic case. I wish we could have done it for today, but unfortunately we couldn't have. So let's go to today's case. This was the second of the two cases. 66-year-old, non-diabetic, history of hypertension and hypercholesterolemia, family history of heart disease, presented with his first episodes of chest pain to the ER, was loaded with dual antiplatelet therapy, and the working diagnosis was a non-STEMI in the emergency room. Go ahead. But the very last EKG before we put the patient on the table showed some remarkable changes. And EKG localization to me is good but not great. But in this case, I think it was we were able to localize what we wanted to do with this patient, really based on the electrocardiogram in his clinical presentation. Go next. So this is the right coronary artery, high-grade lesion in the right, bit impaired antegrade flow velocity in the vessel. Go next. And now you see both lesions in the circ and the LAD. And I think Bob Riley's teeth are probably watering about taking this patient to surgery. Patient was pretty ill and was having ongoing chest pain and ST segment elevation. Go next. And so what we did was, the right was as close to a drive-by PCI as you're going to get. I think you can see that. And then the circumflex presented a little bit more of a challenge. Go next. And because the changes were both inferior and lateral, I wouldn't have known where to, which vessel to do, and gee, do the right but don't do the circ, do the circ, don't do the right. So we did both. Go next. There was no reason at that time to do the LAD. And it was only when we stented both vessels. You can see we got a great result compared to what it was like. We did a multi-stent strategy in both main and side branch, the main branch being that bigger circumflex and the side branch being that smaller OM. And so we got what we think was a pretty good result, and he was pain-free and hemodynamically stable. Go forward. So went home on the usual cocktail of medications. Go forward. And what Mark and I are going to take on today is this LAD. Go forward. He's had some ongoing dyspnea, not much in terms of angina, but dyspnea, a fair amount with activity and exertion. Go next. And that's what it looks like. So a couple of things. Mark, give me your observations when you looked at this case.
Sure. So a couple of things I think are worth maybe discussing. He's non-diabetic. And if he was diabetic, would have our overall approach been different in triple vessel disease when he came in? I think that, is a qualified question now with some of the results we've seen from Freedom and other studies. In terms of what you already have done, it looks great. We've looked at the circumflex. The lesion looks superb. And we're assuming the right's okay. We didn't look at that today, but it was a straightforward. He's had no problems. And now for the LAD, it's a vessel that's sort of got little bites throughout the course with some intervening areas of what appears to be angiographically normal, but will demonstrate that in fact there's plaque throughout the vessel, and this is just remodeling. And so from a technical standpoint, what we decided to do was to protect that relatively a large diagonal branch, as you can see on the angiogram, and to wire the LAD. We subsequently pre-dilated with a 2.0 balloon, and we were interested to see whether or not we could demonstrate some of the aspects of the angiosculpt balloon, and then subsequently went in with an angiosculpt and then IVUSed after that. I think it's important because they've made some iterative changes in their device, and we want to see if it's a little bit easier to get down and to be able to treat these kinds of vessels. And so what I'd like to start off in is where we are now, which is the angiogram you see here. Unfortunately, we don't have a perfect view to show you the more proximal segment and the mid and distal segment simultaneously. So I think what we'll do is we'll focus here as we treat the mid to distal lesion, and then we'll change our view to address the more proximal area. And we're trying to figure out if there's a way, or we did think about whether there was a way to not create just a very long stented area. And I think it's the opinion of David and I that we're sort of obligated to really just take the whole vessel from almost the mid to distal segment back to the left main. And we're trying to maybe convince ourselves by IVUS that may not be required, but I don't think we have much of a choice. So I'll hand it over to the panel now for some of their comments.
So I'm curious, Tim Mort, from the other end, does Freedom really affect this? I mean, you were going to do both of those other vessels, so I guess the only question in terms of Freedom, if he was a diabetic, would you put a Lima on
Correct.
there or not?
So good morning, Mark and David. This is Tim Henry. It's another beautiful day in
Hi, Tim.
Scottsdale. I don't think Freedom really applies to this. This is a patient who effectively had a STEMI. And it's an interesting case because tomorrow you assign me to do you do a culprit or non-culprit? And I think this is an issue that comes up where it's not always 100% clear which is the culprit. And you had two culprits, really. You fixed them. So now, and you did the right thing, patient was treated medically and now comes back with symptoms on medical therapy. And now it's single vessel disease. It's no longer triple vessel disease. So whether this was a diabetic or not diabetic, I would do the same thing. And I think, you talk to the patient about it, but this isn't a great Lima case either. There's a very, very long segment, and, you'd be putting it very distal. And so my personal would be do exactly how you've taken care of the patient.
So let me just give one voice to this technical matter. I think proceeding with the LED is indicated because of symptoms. I think the other two stented areas look fantastic and were appropriately done because you couldn't tell which was the culprit, so you got them both. A little unusual for most of us. The mid segment is long, involves a diagonal, so that's one stent. Then there's an area that's not so narrowed, but the proximal part, at least in the first glimpse, looked to be narrowed. So you could probably get by with two separate areas of stenting. The diagonal area with a long stent across that, and then the proximal area if it needed it, and since we can't see it well. So you might, after you fix the mid segment, make a decision about how much more metal you want to put in proximally. I don't think you need to lay it end to end and get 60 millimeters of stent in this guy if you can help it. So that's just my view.
Okay. That's very fair. So what we can do now, Mort, let's share we did do an IVUS run. I think that provides additional information. So if we could show the IVUS run. And John, I think you're up there. If you could walk us through. We started distal to that second tinier diagonal, okay?
Sure. And there, I think you just went by the diagonal. You saw the
well,
wire that was holding.
We always do this to you, John. Let's
open.
start distally. Just tell me when you're going to start. Go to the most distal aspect of the vessel. I want you to just get your.
There we
okay,
go.
here we're distal. Walk and now drive slowly for John. Okay. Okay, John.
So, relatively small distal vessel. Right in here, I would say you've got a good reference measurement, and then you're into that first lesion. You're going to see the diagonal come in here about 3 o'clock, 4 o'clock there with the wire. Could you go back just a touch there? I just want to see right at the ostium.
Go back just a touch.
Go back up on the screen. Yeah. Right in here.
Go
I just
back.
want to see how involved the diagonal is. Oops. If you can get a frame where you've got the diagonal. No, go forward
Frame it
again.
with the diagonal in the same frame. Yeah.
Yeah, I just want to see the bifurcation of that diagonal.
So it's right. It's coming in.
Should be coming up here in a second. You'll see the wire dancing in from the lower right in a sec. Here it comes. Okay, now go real slow here, frame by frame.
No, frame by frame.
There you go. Okay, so that
You want to see
diagonal
the
looks
diagonal.
pretty good
Perfect.
here. There's not a lot of disease there. In fact, most of the disease in the LED is opposite it, so I'm not too worried about this diagonal going down. It's appropriate to protect it, but that IVUS image would suggest that the diagonal is probably going to be okay. And then as you come back, I'm
John,
looking
could you
mainly
maybe
for
comment?
severe calcification, and I haven't seen a lot yet.
Correct.
John,
big,
could
bulky
you maybe
plaque.
comment on non-direct imaging of a side branch, sort of the inferential imaging
stay right there.
that we do, and we make decisions on the diag from an IVUS in the LED. It's been called inferential imaging.
Yeah, I mean,
is that an
typically
okay
that's
thing to do?
typically
Are there
that
shortcomings?
we would teach that that's not the way. If you really want to know what's in the diagonal, you got to go into the diagonal. But it's free information here, and it just gives me a little heads up that there's not huge amounts of plaque in that diagonal. I'm probably going to be okay. It just helps me think about how likely I am to going to have to put a second stent in there. And so far, I would say I'm unlikely. But I'm not judging the physiologic significance or anything else. I'm just getting a quick look. And the studies from Korea would suggest that works.
So let's continue to walk more proximally. Is that okay?
Yeah, perfect. And so the two things
here
I'm
we
really
go.
looking for
And
here would be
slowly.
severe negative remodeling or lots of calcium. And so far, I just have a big concentric pack with a little bit of calcium with some remodeling.
Okay,
There's
stop
a
there.
little disease-free segment, but I a little bit disagree with Mort. I'm not going to spend a lot of energy trying to save 3 or 4 millimeters between the ends of these stents. I would just lay them in end to end and make sure I cover everything. Keep going
you
there.
saw the plaque proximal to the diagonal. Now you're in the sort of the mort zone, we'll call it. Where
Yeah, it's just this little spot there that's okay. And if there was no proximal lesion, sure, I'd end it here. But keep going.
I haven't committed to not
Stop
stenting.
there. No, we're just being, we're just being hyperbolic here. So this is more proximally,
Yep.
this is now the mid LAD. Keep walking through it, please.
And then it gets, it gets pretty
Just a
tight
ton
here.
of
So I don't think
plaque,
there's
right?
a lot of question here. It doesn't have a lot of remodeling, but I think it's still pretty big. I wouldn't be worried about putting a
Look at
generous size stent there. Huge bulky plaque, maybe with a little bit of, lesser density stuff that might be considered to be vulnerable. Now you're back at either a septal or a little ramus or something there.
Correct.
And there's a
Yeah, I
big,
think that's that.
big section of calcium
yeah.
on the right there. But what you're going to find here afterwards is you're going to expand the stent's going to expand to the lower left to 7 o'clock. And that big bulky thing's going to still be there. And then you're into a more concentric plaque here. This is easy here. And then I think you're going to hit the left main. So I think you got to go all the way back to
we're
the left
still,
main. Yeah, you're almost there, I
And we're
think.
fortunate we have yeah. So I'd like you to sort of slow down as you're approaching the left main. So he's
So
pulling
you've got a
back
little
further.
cuff
We got a
right
little
there. I
bit of
think you can
freedom
land
there.
it there.
Yep, that's our freedom. That's our free zone.
And then you
here
got
comes
either
that's
the
the circ.
circ or ramus. Okay, so you've got a pretty nice cuff at
Right.
the proximal end. You shouldn't have any problems not overlapping that circ.
3038. Okay, so
So
we're going to.
can you show the spider view, Kendall? I'm going to have Ken put
Thank
the
you,
spider
John.
view. John, that was terrific. I'm going to have him show. Yeah, that's the view. Go back one. So, correlating with what you said sonographically, you can see that little cuff or that free zone there with no disease in it. And I think that would be an appropriate landing zone for our proximal stent.
Yeah, perfect. So we're going to start with a 3038. I guess it's an expedition. Is that what we're using? Okay. And we'll just land it distally and see how we do.
A couple other technical things. I'm pretty certain that I wrapped these wires. The diag went down smoothly. The angle was such that the wire had a predisposition for the diagonal, including the wire I was intending to put down the LED. So I may have wrapped these. It'll be interesting, I think, to see going forward what difficulty we have getting the stent into the LED past that diagonal with the small amount of wire wrap that we have.
So Mark and Dave, it's Manish
Okay.
here. Good morning. Great case. Just
Hey, good morning, man.
Hey, Manny.
for the audience, you guys are bifurcation experts. This is a 38 and a 28, and I think it's the right thing is to lay stent end to end with the IVUS confirming that. But teach us a little bit about how you handle that diagonal bifurcation and when you would think of something different other than provisional here, David. How do you decide?
Well, complex question. The more disease there is in the ostium of that side branch, the bigger that side branch, the more likely we are going to have to alter our treatment strategy, especially if there is a suboptimal result or a significant amount of plaque shift into there. And boy, that stent just flew down there. That wasn't hard at all. But I think it's really a dynamic process, and we base it on how much disease in the side branch, how much plaque shift, and also if the patient's having symptoms and if there's persistent electrocardiographic changes. I think keeping it simple, Jim Hermiller applies the KISS theory to these. I think he's absolutely right. Keep it very simple. On the other hand, don't be afraid or paranoid about shifting strategy, shifting gears when you have to.
So David,
we're
what
gonna
again have you done in
probably just
terms
try
of
to-
lesion prep here? What did you do
don't know,
before you
explain.
got to hit this point?
We used a 2.5 angiosculpt, went down past that one small diagonal branch.
We should just go. He gets EKG changed with
Yeah,
a bunch
we
of
gotta
stuff.
inflate.
No,
So-
keep going,
Want me to inflate
please.
it?
You inflate and I'll talk. So what happened was we used an angiosculpt about down to the tip of where the distal tip of that stent is, and we got a nice profile of the angiosculpt, and then we went and IVUSed, and so you saw basically the angiosculpt and then the IVUS. Okay, so let's see what we got here.
And I think with the new longer stents, this case becomes much simpler than it used to be, where you needed to put 3 or 4
yeah.
stents.
Okay.
So now we got
Dave, your
something
strategy
going
with
on at
the
ostium of that side branch.
your strategy with the wire and the diagonal there, of course, it always looks kind of funky like it does there, and we can figure that out later. But
Right,
do you go
right.
to high pressure in the main stent before you pull the wire, or do you go to some intermediate pressure and then pull the wire and rewire? How do you do that?
I tend not to go to high pressures. because you can always come back and dilate the main branch. My concern is always trapping that wire and not being able to get it out. Now, that rarely happens, but I think you're going to predispose to that with the higher pressures that you go. So you can always come back later and do higher pressure dilations, but not with the wire trapped. Now, that's my prejudice.
And do you
Be
do?
interested if anybody else has a different approach?
You do a wire swap now, so pull the LED wire back, go in the diagonal, and then
Slightly
swap
more
them,
cranial.
or do you take the diagonal
Well,
wire
we'll see.
out?
I think I'd take the diagonal wire, or put just a third wire in. You can do any one of several things.
Okay, I'm going to do, we moved the camera a little bit just to catch the more osteal area. Okay, sitting. Oh, you got it? Sorry about that, buddy. Good. Okay.
Yeah, I mean,
Now the diag, which is foreshortened, looks much better.
Yeah,
So we're
it's
just
always
trying to
good when you
figure
can't
out
see it.
stent length here.
Exactly. It's part of our Valentine's Day Don't Ask, Don't Tell special.
Okay, so we're actually at 38 covered a lot of real estate. So I think we're talking, what do you think, David? Somewhere in the about 20, 28?
Well, why don't we, okay.
Well, you could,
That's actually even less than that.
you're using the IVUS with the markers, right? So I found that very useful. We could also take that 38 balloon you've got there and use the markers on that to help gauge it. But you certainly don't want it to be too long there. You don't want it hanging out in the left.
No, we don't need, and we don't need tremendous amount of overlap either. Yeah.
So he's not having any symptoms right now, which is good. You're not having any symptoms, are you? Okay.
So I mean, you can take this time to just IVUS check that proximal. You'll know exactly how long, and then swap your wires. And
The other thing we do, what do we have? What was that 2.5? We had a 15.
2.515. We can take that back out.
Yeah, just give me the
David?
2.515 real quick, and we can just use the markers from
Yeah.
there.
Could you tell us
Or,
the LV
yeah, just one of the
function?
balloons. What was the original? A 2.015?
Normal EF.
What was that, 201?
Pretty normal looking EF. We got to him pretty quickly. And remember, the ST segment elevation was really
15?
a very
Give it
brief
that.
time when he was just about to go on the table. So he really he's enjoyed really good EF. He's about a 50% EF, no significant wall motion abnormalities. I think we're very fortunate to have crossed those things as quickly as we did.
So we have a 2.015 on the table, John. So we'll just use it as a marker and figure out what stent length, because as you suggested, we don't have to mess around, and we don't have to go back in with the IVUS. Sorry about that.
Dave, do you really care how far that wire is out in the diag when you're sort of worried about trapping it? Do you pull that wire back a little bit, or have you just found that not to be a realistic concern?
I found that not to be a realistic concern, and in fact, before we went live, that wire kept coming back with every manipulation. I actually pushed it out a fair amount farther. I think it may jinx myself, but I think trapping that wire is generally not a big deal. I just don't see that as being something that I'm not able to manage. Every once in a while, and now that we're live, today will be probably once in a while.
So we're in the stent there, and we can see where we are. And as John suggested, we'd like to nail this really nice. So this is is that my scout from this view? Okay, perfect. So we've got a beautiful landing zone there. So I'm going to take a picture here. Is that okay?
Yep.
Perfect. So we're in the other stent, and we're short. So probably that's a 15, so we just got to go a size bigger, 18, right? Or you want to go a little
What do
longer?
you think, 23?
23.
23 would be, yeah, that would take the science, that would make it less of a science project. We have a 3023, guys.
So to finish Dave's, the question that Dave asked, I really don't worry about that wire in the side branch, and I actually just tested it, and it looks like it's moving back and forth pretty freely.
so
So just as a
Mark, I'm
comment,
curious why you
when
picked
I'm sorry.
I'm just curious why you picked a 3.0 there. You're likely going to go
Should we
back
go
and
3.5?
dilate this. So I mean, why not just put a 3.5
Yeah.
proximal?
It's a great question.
I agree. If you didn't, it's actually the
3.0
right
and a
choice.
proximal LED
as I
is way
said
too
it,
small.
No, I agree with you. Can we have a 3.5, please? Completely agree with you. After I said it, I sort of wanted to change my strategy.
That's
I kicked
why
him.
we're here, Mark.
Yeah, thank you. The other piece is just as a comment for bifurcation stenting. I think we're going to wind up having some overlap here, and I guess the critical piece is if there was the side branch coming off where there was the overlap, that's when you really got to be careful about how much you're overlapping.
That's when you don't want to put 2 layers of metal, redundant layers of metal, over a side branch that you may want to access. Then I think you have a little bit more worried about incarcerating your wire.
Incarcerating, I like that.
Like that?
So why not just pull it, Dave? Why not just pull your diag wire now and not take the risk of trapping it along a long LED?
Want to do that? All right, we'll do that. We can re-enter with the LED wire. So let me come back with that, just to show you how easy it comes back, no problem whatsoever. And so.
Okay.
So since I think you're going to have a long enough
I'll need a new
stent, you want to pick a view that's going to really allow you to get the proximal end right. And I think in this case, something like an RAO caudal or something is really going to let you nail that proximal end to be sure you're not overlapped. Or
We'll start here. We'll just make sure we're good here, and then we can sort of move it around. So we're going to go for the overlap distally here, and then we could go spider, we go to RAO caudal, whatever sort of makes sense. So there we're overlap beautifully. And I'm going to give you a little more puff here just for
hang on a minute.
For
hang on
grins.
a minute.
Yeah.
Go.
Okay.
That looks pretty decent right
You
there.
guys
Why
are
don't you give me
making
a
this
spider
look
view, please?
easy, so I'm going to get Duke warmed up in the bullpen if that's okay.
That sounds perfect. All right.
Toot that.
You ready?
Yep.
You gotta
Back
pull
a little
yeah.
bit. Yeah, I agree.
Abyssal
Because
back.
I'm really overlapped there.
Yeah, I think you got plenty of, we're definitely overlapped
Okay,
plenty.
toot that.
Okay. What are you saying, tooted?
Toot.
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 Really?
T-O-O-T.
That's a real word?
Yep.
Okay.
In Scottsdale it is.
Wow. All right. I'm tooting. All right. Here we go. And we'll take a real picture here. Is that right?
Yep.
Okay, I'm just, let me pull up more contrast. And it's the exact opposite of my lab, so it's really fun.
Ready?
Okay, sure.
Go. There we go. I like it.
I think we're overlap plenty, right?
Yeah.
Okay, good. You ready? Yeah. You ready?
Go.
Okay, good. Going up?
Are we still, you guys still with us?
Yeah, we are.
We're enjoying the
Okay.
two of you
Wind up.
talking.
So Mort, Tim, Sahil, Manish, we're going to IVUS this after we
Chest
post
Okay, good.
Absolutely.
dilate for sure, right?
Yes.
Okay.
Save that picture.
I'd use the 3.5 balloon to,
Now,
to
here's a question,
dilate distally.
Dave. Dave, here's a question. Should I rewire the side branch now or just kind of wait? What would you recommend?
I'd like to look at it for, let's go back to the RAO cranial real quick.
I might just
straight
post-dilate the
RAO,
hack and go.
AP cranial, whatever. Yeah.
Okay.
Dave, I would
You know,
rewire it. It's
you had
simple.
the-
You've probably already got the wire sitting in the guide, and then you can, high pressure dilate with impunity down there. Not worry about it.
Yeah, I agree.
Okay.
See what it looks like.
I agree.
I
too.
think you said you didn't go to high pressure with the original implant balloon, so
We
Did not.
did not.
you're gonna, if you're gonna protect it at all, then go ahead and protect it while you're ballooning.
This is the time.
Angiographically,
Would you consider doing an IVUS now and see what it looks like?
Absolutely not. Not until the angiogram looks good.
I mean,
I can guarantee you it will not be expanded yet. It's a waste of a run. Just go in and do your high pressure dilatations until it looks great, and then IVUS.
Okay, let's rewire the.
Okay,
diag.
so
Can we have the pro? You want pro water?
sure.
David,
We'll take the pro water
the
back.
diagonal looked to us like it had some haziness at the origin, ostium, and to you as well.
I agree.
So you're going to have to make a decision
Yep.
about stent or no stent, or assess it or not assess it.
So would you talk to us about some of the fantastic data from Dr. Koo's lab on jailed side branches?
This is I love this stuff actually.
Yeah, so this is a real interesting case which demonstrates exactly what they tested. So when the ostium of the jailed diagonal was angiographically less than 75%, they rarely found an abnormal FFR. And when it was more than 75% narrowed, they found an abnormal FFR in about half the cases. So most of the time, even though it had material shifted into it, and angiographically it looked a little different because the stent struts crossing it, the physiologic impact was not always as bad as it looked to the eyeball. and they could avoid messing around with it.
What do you use, quantums? Or?
However, they did, you need to spend a little energy with an FFR wire in there to see what's going on.
Take a balloon.
But it's one way to avoid managing a complicated diag. The other option is just always, go back and finish it off.
3 or 3.5.
Distal?
So Dave, did you measure that distal reference from the IVUS before? Do we know what that was? What the diameter was distal?
We have what was that distal reference, guys?
As he's
2.5?
doing that, more, don't you think that there's
Give us a 3
diagonals
out
and there's
and see.
diagonals? I mean, this is a very large diagonal. And when you do a trial like that, we talk about bifurcations as if they're all the same, when really they're all different.
You okay with 3.5 or bigger?
This is a very
3.0.
large diagonal. I mean, it's arguably almost as big as the rest of the LED. So
15.
this is more likely to have an abnormal FFR, don't you think? Because the size of the territory matters.
So
I don't think there's any predicting. I think that's where the point of Mort's discussion. It's very hard to predict what's going to be functionally significant and what isn't with these jailed side branches, because they can look pretty nasty and yet not be functionally significant, according to what Kuh's paper suggested. Mort, is that about right?
That's
yes,
right.
that's exactly right. And the issue, the size of it is irrelevant because it could or could not be important. Obviously, the higher the flow, the more clinically important it is. And the smaller the territory and the smaller the vessel, the less clinically important. But it doesn't impact the knowledge of, is it flow limiting or not? Now, this is an important vessel, so it's more important to get the right answer, I think. You can treat it.
Yeah,
that's a standard approach. You could measure it if you said, well, I really don't want to treat it for some reason. So,
Mort, I think the other thing
I would measure it more.
I think the other thing that's important is they've also done the studies to show that the FFR is stable over time. So if you measure it at 0.88 now, in 6 months, it's still going to be 0.88. It doesn't, it's not recoil. It doesn't get worse or anything like that. So you can be pretty confident what you measure acutely is going to hold up long term.
I agree.
So what size balloon do you guys have?
I think it's more. Do you know the analogy I use is it's like a screen door. It's like a screen in front of and the blood could flow through it, and it just may not look good.
I think side branch and osteal angiographic imaging is very tough to know whether there's a true narrowing or not. And I think IVUS has shown that. If you have an aorto-osteal lesion, depending on the origin of the daughter branch from the parent structure, the aorta, it can be very deceiving. I mean, these are the source of angiographic artifacts that have caused trouble for us for a long time. Here's a quick method to assess whether the flow through that angiographic abnormality is worthy of your energy, and perhaps another stent, and a whole complex series of steps which could be avoided if it's normal. Now, if you're already convinced that flow is sluggish, or there's a lot of material that looks really bad, or for some other reason, you don't need any of this discussion, and you don't need an FFR. It could be a quick assessment. Boom, you're in, you're out, and you've got your answer.
How high are you guys post
I also fundamentally think it's this. I'm going 18.
What size balloon do you have?
I'm going to cine this.
That's just a 3.
This is a 3?
Go ahead.
I think you're okay. Yeah. I didn't want. That's what we took distally, just a 3. The reference distal was reported 2.5. You said. Way distal. Okay.
Yeah, it's
That's,
underexpanded though.
Thought,
the vessel's collapsed. I mean, I think Manish and I were talking about probably a 3.25 distal, and then clearly at least a 3.5 or 3.75 proximal.
Mm-hmm.
So let me ask the panel, is there any time in which you're not putting a 3.5 or greater stent in a proximal LED that's big? I mean, is there a time you ever put a 2.5 in a proximal LED?
A 90-pound Korean woman.
Yeah, in the Asian population. It's definitely not, right?
No, I think that would be a rare circumstance, a 2.5 and then a prox LED. Maybe there'd have to be a specific reason, right?
Dave, Mark, tell us what you wanted to do. We're sort of coming up against the halfway point here. I'd like to sort of finish as much as we can.
let me do a quick IVUS and then come back, and then we'll let you go, okay?
Okay.
How the IVUS cuts look,
Go,
please?
Dukes.
Is that
Mr.
all right?
Neal, I think you can hear me. Nod your head, get warmed up with the fastball.
We'll just do it. I just want to see what it looks like distally and proximally, and we'll be done. Go back to the AP cranial, guys, please.
So can we, after they've worked a little bit and we've kind of finished up here, can we come back and just show a final picture?
Yeah, and we can figure out.
It's
We'll let you
your
know what
course,
we did
Dave.
with the sideburn.
We can do anything you want. It's your course.
Go ahead, Dave.
I like that.
Thank you.
We have till 9:45 for a hard stop.
Okay, good,
we're
good,
good.
good, good.
Okay, I'm going to also give you a puff in the, just a little.
a toot.
Toot in the.
Ring down, please.
Toot
Great.
you while you're ringing. I just want to see the diagonal.
That just goes through
Good.
so nicely.
Yeah, looks great. Okay, John, you're on. Let's go
Okay,
to
distal to the stent there. This looks like at least 2.5, 275 diameter.
Pulling
So we're
back.
going to look at where it joins the
Stop
stent.
there.
Good. The stent is bigger than the distal. That's good. Now we're keeping that sort of circular image. It's narrowed here. That's where I thought it was going to be trouble. I would go higher there.
We went to
Diagonal's going to
18
be
there.
coming in. Yeah, I'd go at 325 into the 20s. Here comes your diagonal. Now, right above this, it should be fine. This was the sort of disease-free zone. So I'd try to match that area. And then it's underexpanded here proximal, too, a little bit there. And I'm going to guess when you get into that big bulky plaque proximal, it's going to be not as big as you'd like. Not as bad as I thought
John,
it might
what's
be.
the.
And there's the circ,
John,
and
we've-
you're
it's the-
just right at it. So that, I
John,
can't... yeah.
the stent, do you agree the stent's completely opposed
Yes.
to the wall everywhere? So what's if I walk away right now, what's the restenosis rate? As opposed to if I go in with a 325 or a 35. Everywhere it's opposed, right? It's not fully expanded. What am I gaining from a restenosis or durability aspect by going back in, potentially risking the diagonal with plaque shift, and that would be the only real risk to going with a bigger balloon. Am
Well,
I
it's a-
significantly reducing my restenosis rate?
Well, I don't know if I can tell you for 55 millimeters of stent involving 3 sections of the LAD, but I mean, in general, the LAD has a higher restenosis rate, and the studies do show that even in DES, the spots that restenose are the ones that were relatively underexpanded. I guess I don't see a downside to doing it. I've not experienced the downside to trying to get these fully expanded, with the caveat that I don't go bigger than a 0.5 millimeter over the reference diameter at high pressure. So if I can get what I can get with up to a 0.5 millimeter bigger, I've not experienced a problem from that. But I don't know that I can predict the exact restenosis rate in this guy with this much metal.
Yeah, but it's always a question for me when you have a result where you have great opposition, everything looks, circular, the flow is good. If you just look from the clinical studies, long 3.0 stents, probably he's in the restenosis rate double digits, but I'm just curious if you thought there's a significant gain if one wanted to walk away at this point. And
Well,
sounds like
early studies
that's great.
suggest that
I
you
gave
don't
a little
need a lot.
nitro to perk up that distal area.
You don't need a lot of increase in minimal cross-sectional area to get a pretty big drop in the TLR rates. How about the other folks on the panel? Would other people keep moving here, or are you happy?
There's a lot of ways to do it, and you have an excellent result right now. I mean, personally, and especially if you're getting in these days of ACOs and things like this, what I would have done is with the proximal 3.5 balloon, I would have just gone distally with that personally and post-dilated the whole thing out to close to where the distal end is. Because I think you're well opposed at the distal end, and you don't want to make that any bigger out there. So that's what I would have done and not used another balloon. And personally, I think the diagonal actually looks right. I think you could do FFR, or you could just stop right now. I think either way
Should be
would be
free flow in
okay.
it.
Can I ask a loaded question here, David and Mark? Should I use OCT here as well? Can I get by with OCT?
As your primary imaging system?
Yeah.
That's a good question.
You're blinking your eyes, David.
Well, here's a question.
No, it's a very good question.
Why not?
Yeah,
Why couldn't you?
certainly
I
could.
think they're both great and almost interchangeable technologies, and I think you can really, the information that John just discussed with us, I'm pretty sure you can get the same information from OCT. A little bit of setup, but you know, I think they're competitive technologies, and we get great information from both of them.
All right, Dave, Mark, someone has to be the bad guy here. I've got to sort of move over to Duke, and hopefully we'll have a few minutes.
Okay.
Come on back, okay? And you can holler at me
Great
later.
case,
Yeah,
guys.
absolutely.
Thank you.
Sunil?
That's all good. Thanks, guys.
All right,
Elio
guys.
Crane
Thank
over.
you. Great job.